Thank you. Good morning, everyone. I'd like to start by turning my cell phone off, hitting the resume button so I know how much time I have. All right. So yeah, it's wonderful pleasure to be here in Vancouver. I had the opportunity to visit in June of 2014, so thanks for inviting me back. It's good to reconnect with old friends, meet new friends, and just being in Vancouver is awesome. My condolences to Blue Jay fans everywhere. Last night was really a hand-wringer, wasn't it? It was a really exciting, but leaving all those men stranded on bases in scoring position is kind of, I think, their undoing. Congratulations on the recent election. I hope that has a good outcome for healthcare and for people with disabilities and for the people we care about. So yeah, exciting times, some opportunities ahead. I was asked to speak on physical and mental health and how we could optimize some of these things to make sure that our loved ones are doing the best they possibly can. I want to just take a quick survey. How many in the room are parents or family members of kids with Down? Okay, and how many have a child over 18? Okay, and the rest of you, I assume, under 18. How many under 5? 5 or 6? Okay. All right, and how many in the room are therapists or educators or healthcare people? Okay, oh wow, great. So some of you are some of you duly diagnosed, parents and healthcare? Okay, all right, cool. So well, thanks for being here because your being here is what's going to allow the message to carry into your profession and your day-to-day work. Okay, so these are the people we care about. And children and adults, and I'm going to be addressing healthcare issues related to children, adolescents, and adults. So if you're the parent of a very young child, I don't want you to get anxious or worried about the things we talk about in adulthood. And if you are the parent of an adult and you've already heard all this on children before, I just ask for your indulgence and patience. Because remember, you're the ambassador for other families you encounter socially. And as you start to tell stories, there's so many ways in which you can be of support and help to those other families, partly by knowing a little bit more than just your personal situation. So healthcare has become really front and center because people with Down syndrome are living so much longer than they used to. We recognize many specific conditions that go along with Down syndrome. We know more about their treatment and in some cases prevention. There's been in many countries a direct promotion of healthcare best practices to physicians. There's increased access and availability to care in many countries, not all countries. And even participation in clinical research, I think, has led to changes in treatment and understanding that have directly impacted healthcare. But it would be fair to say these improvements have been uneven. So in some regions of some countries, there's limited access to resources, uncertainty about what is best practices, or even what is considered minimally standard care for someone with Down syndrome. And then there's always the question of how do we provide standard care to people who are very complex and somewhat difficult to understand. So there's lots of room for improvement and leveling of the playing field everywhere. Now, the person who I think of as being the real leader, pioneer in healthcare for individuals with Down syndrome was Dr. Sig Puchel, who passed away about 2.5 years ago. He was an amazing person, Here he is sitting on top of Mount Olympus, I think. But he was a parent, a wonderful clinician, a researcher, a mentor to many people, a wonderful person, a speaker, and he knew that there were different types of medical conditions that come up at different times during lifespan that are important to consider. So during birth or in the neonatal period, we tend to think about congenital birth conditions like the congenital heart disease, maybe the tendency to have a GI obstruction. Some kids have cataracts or congenital hearing loss, and that's one category of medical condition that most pediatricians learn about pretty quickly in their training, and most physicians sort of can remember this aspect of Down syndrome. There's, however, quite a list of things that can arrive on the scene, so to speak, during early childhood or the school age years. And for lack of better understanding, we say that they're acquired, so they manifest themselves during this period. Then there's age-related issues that take place in people with Down syndrome, and many of you may know that aging in general is somewhat accelerated in people with Down syndrome. So in many dimensions, not entirely all age-related illnesses. So for instance, things that we see in the general population, like increased in solid tumors or cancers, or increase in atherosclerotic heart disease, or increased blood pressure, hypertension, are things that we don't typically see in people with Down syndrome. So that's kind of nice. It's an interesting philosophical question, though. When does development end and when does aging begin? And how is it that a single individual can experience both? Delays in development and accelerated aging. What's the connection there? So there's people who, of course, are very interested in this, and there are some intriguing ideas that are being followed up on. I'm not going to address that. Some of the barriers that are faced by our population include, just being unfamiliar to many primary care physicians, beyond just the real basics of Down syndrome, and it's hard for physicians to get past that, so that a lot of the difficulties and problems get ascribed to either Down syndrome or intellectual disability. Or if you're older, everything gets lumped under Alzheimer's disease. And we know a lot more than that. We can do a much better job than that. And as I mentioned, this notion of what are the minimal standards, the best standards, how do we interpret complex individuals? Those are things that we all need to work further on to educate our medical colleagues. Screening, the question comes up, should we just screen for everything? If we know that these conditions are somewhat more prevalent, or we think they're more prevalent, why don't we just screen everybody with Down syndrome? Well, nice thought, but not every condition has a reliable screening methodology that's effective, specific, and cost efficient. And we know that governments and healthcare systems pay most attention to cost efficiency and the yield on a certain screening test. So can we move to just screening high-risk individuals or people who have symptoms? That seems reasonable, but that's where we need to educate clinicians to understand who's showing symptoms of what and who's considered high risk based on other factors that may be present. Alternatives to screening may include a high degree of vigilance, a high degree of suspicion, and quite simply asking the right questions. When you're in the room with the family, families are amazing observers, and it's a matter of kind of getting them to to answer to the right kinds of questions. But it can take a while to be at that level of the game, so to speak. So I think that screening has actually improved health outcomes and has been cost efficient and effective. Notice I say I think because I wouldn't say I've read a lot of data on the economic impact or the improved quality of life impact. However, I think it's pretty obvious if you pick up congenital heart disease and repair it in the first couple months of life, that there's no doubt improved longevity and quality of life for that individual. Same with gastrointestinal defects. In the newborn period, screening hearing and screening for thyroid disease no doubt picks up many people and helps them to have better lives. We need better evidence for areas like sleep-related disturbances, because we know that there's a lot of sleep-related disturbances in Down syndrome, and it's clear, I think, that it's not being appreciated, diagnosed, and/or treated even once it is diagnosed. And this is what we call a modifiable risk factor, and it has a huge impact on learning, cognition, behavior, and just overall emotional well-being. So I'll be talking about that a little more. We also need better evidence for neurobehavioral and mental health disorders. Again, we know that we kind of know when a change has taken place and when something is not right, but some of these conditions are interpreted very differently based on the person observing, their training background. Are they using any kind of screening instrument at all that's got some reliability, some specificity? There's just a lot more discussion that needs to happen on this. And of course, early dementia, screening for early dementia, right? We think that that's going to be very valuable to pick up on that one early. Even if we don't have a specific and effective treatment today, I think that they're going to be coming down the pipeline very, very soon. And there's the whole notion of preparing, educating, and working with the family to anticipate the needs for the individual who may be showing signs of dementia. So there's lots of reasons why screening and monitoring and all these things make sense. The American Academy of Pediatrics has some pretty specific screening and health maintenance guidelines that are available in Spanish, and they're also available in a family-friendly form. And this is AAP Health Supervision Guidelines 2011. You can Google it or go to pediatric.aapublications.org. I also believe it's in the process of being updated. Every 5 years it's going to be updated. So I've heard rumors that it's happening. So these guidelines are based on expert opinion, supported by published evidence. They're not entirely what we call evidence-based because we just don't have the body of evidence in people with Down syndrome to know what is absolutely the best, which is kind of a good thing because it calls attention to the need for more research, specifically clinical research, which has not always been happening in the way that it should, particularly in proportion to the need of our population. Anyway, this document provides guidance to primary care providers, meant for people in the US, but applicable to people elsewhere. And there are specific action items that are dictated or articulated in this document to assess, to evaluate, to measure, to administer very specific kinds of things based on the person's chronologic age and presence or absence of symptoms. So pediatricians and family medicine people benefit from having this kind of information in the patient's chart, either in electronic form or paper form. And that's one of the things you as medical ambassadors can do, is bring these articles to the attention of the physicians who are usually, I think, happy to receive the information, you know, especially if you're polite and you promise not to quiz them on it next time, I think they'll be happy to receive it. The newborn issues that we're most concerned about, I think, are familiar to people: GI anomalies, cardiac anomalies, vision, hearing, a blood count to look for polycythemia, which is a high red count, or a high white count that may indicate a pre-leukemia situation. And then during childhood, ongoing evaluations of vision, hearing, thyroid, iron level. You would check a ferritin primarily, growth rate, dental checkups, close monitoring of development, behavior, sleep, all these things which can emerge in childhood, and on top of routine vaccinations and routine care. So there's a lot to do, right? And I'm not going to go into the specifics of everything on that list. I just wanted to hit those high points. By the way, some of what I'll be saying is not in the handout that you have. I worked on the talk yesterday and this morning. So sorry about that. Okay, so frequently asked question. Can medical conditions impact behavior, attention, activity, learning, executive control, which is kind of self-regulation, planning, organizing, those kinds of things? And yes, they most definitely can. So what's the connection? Well, sleep is a big one. We have frequent reports of excessive movement during sleep. We know that a lot of our kids sleep in a funny position. They may be bent over at the waist. They may sit up a lot during sleep. They may like to sleep leaning against the wall, all kinds of things. And then there's also the respiratory part of sleep. Do you hear snoring? Do you hear respiratory pauses? But no single sign is reliable or specific for sleep apnea. Even snoring. Some kids have such a crowded, tight airway that they can't make the vibratory sound of the soft palate to cause snoring. It's just too tight in there. So the tongue sitting up against the soft palate kind of dampens that effect. So you don't really hear, but you may observe gasping, choking, and the periodic breathing. There's problems with sleep initiation, which is falling asleep. There's problems with sleep maintenance. And sleep maintenance problems in particular are made worse by what? Asthma, symptomatic reflux if you're vomiting or gagging, nasal congestion, right, due to cold, sinusitis, cough, just feeling bad. And there's no reliable way to tell if someone is having significant apnea unless you do a formal overnight sleep study, or you have a very reliable form of home monitoring, and there are several that are emerging that show good reliability, or you as parent actually observe your child during sleep. And I don't mean casually peeking in after the late night show is over and just checking on them and then going to bed. If you're really suspicious about a sleep-related issue, you need to be on guard between 1 and 6 a.m. A lot of sleep-related issues happen in the second half of the night. That's when your REM sleep is at its highest, or supposed to be at its highest. That's when muscle tone in the airway drops to its lowest during REM sleep, and that's when obstructive events are highest. So, sleep is important for all of us, for mammals generally. As humans, we spend 30% of our lives asleep. There's a cyclic occurrence throughout the night of rapid eye movement and non-rapid eye movement sleep. The first half of the night, non-REM and some slow wave sleep predominate. During the second half of the night, REM sleep and a lighter stage of sleep called N2 predominant. And these hitting these different phases are really important. This slide shows you the red is the REM sleep. The gray immediately adjacent to the red shows stage 1 sleep. So stage 1 sleep becomes less throughout the night, and REM sleep or REM density increases throughout the night. If you look below, these look like buildings. This is called sleep architecture. I think you can see why, right? It looks like, well, maybe not the Manhattan skyline, maybe the Vancouver skyline or the Toronto skyline, I don't know. But anyway, the gray below shows stage 2 and delta sleep, which is stage 3, and that predominates throughout the night. So sleep is important because during N3 slow wave sleep, you consolidate memories that are learned during the day. And if you have more slow wave sleep, better slow wave sleep, you're going to do better. Arousals or apnea cause a break in the sleep. They cause a break in that architecture, so you don't hit those different stages of REM and non-REM sleep. The single best analogy I can think of about memory consolidation and the importance of sleep is it's like syncing your iPhone to your computer at night. Okay, if the iPhone captures the events of the day, audio, visual, whatever, your notes, when you go to sync it with your computer at night, it gets integrated into your long-term memory based on the computer. So that's kind of an easy way to remember it. Trouble falling asleep can have many causes. Busy home environment, too much daytime napping, which can cause a circadian shift. Some of our older children and adults who prefer to stay up really late and sleep into the daytime. It's a problem once they finish school and they're on their own a little bit more. This can really start to show itself. Or if they're on their own in a group home and it's not so well supervised, you can see these changes in shift occur. Too much computer or screen time. This whole notion of behavioral resistance or anxiety related to not wanting to go to sleep. And then, of course, medications, right? I hope your kids are not consuming large amounts of energy drink or energy gels. But, you know, caffeine in any form, soft drink, chocolate. Stimulants used for ADHD, so like Ritalin, Focalin, some of these things will interfere with sleep. Bronchodilators used to treat asthma, you know, your albuterol inhaler can interfere with sleep. Antihistamines, certain types of antidepressants can interfere with sleep. Trouble staying asleep may have a slightly different causality. The room is too hot, the room is too dry, the child's thirsty, their bladder's full. So take care of all that stuff ahead of time. If they have very restless limbs and are motorically very active, you probably want to check a serum ferritin level to see if they're iron deficient or insufficient. And it won't necessarily show up on a CBC as anemia. So this is not the same thing as iron deficiency anemia. How do you spell ferritin? F-E-R-R-I-T-I-N. Yep. And then, of course, the other possibility is this sleep apnea. Okay? The other thing to remember is that kids with different neurobehavioral conditions, ADHD, anxiety, autistic-like behavior, those kids may not have regular sleep rhythmicity at baseline. Even if they don't have sleep apnea, or even if they don't have reflux or sinus problems, right? Just the neurochemistry of the sleep pattern is off, and they may need help with initiating and maintaining sleep. So for obstructive sleep apnea, The risk factors include a whole host of airway issues that you may be familiar with: small mandible, crowded oral cavity, narrow upper airway, enlarged tonsils and adenoids. Adenoids can regrow, tonsils not typically, but you can get something called lingual tonsil on the back of the tongue, which is sort of an atypical place for tonsils to grow, but it seems to be an issue in our older adolescents and adults. So even if as a child you had your tonsils removed and sleep apnea was, quote, cured, you can redevelop it for other reasons as an adult. So for that reason, it's always on the radar screen, or it's on my radar screen anyway. The other risk factors include, again, the decreased tone during REM sleep and the reflux, the asthma, etc. So the treatment options for sleep apnea include start with like nasal decongestants, saline spray, steroid spray. They even make a nice aloe eucalyptus gel that you called Zicam, and you just spray it in your nose, or you could swab it with a Q-tip, and it kind of opens up your sinuses and your airways, and it feels pretty good. And good luck trying to get your kid to let you do that. But you may have success. Then there's sleep position. But how do you get anyone to adhere to a single sleep position? Sleeping sideways, or actually allowing them to sleep sitting up, although it may not look good to us, may be a highly adaptive thing for them to do. The other thing that, of course, that they like to do is to sleep bent over with their hips splayed open, lying flat. And while it looks uncomfortable, it may actually be kind of a comfort position for them and protect their airway because they're in a prone position. So gravity pulls the tongue and the soft tissues away from the airway. I also have some older folks who have severe obesity, severe apnea, and I recommend them sleeping in a reclining chair rather than flat on a bed. Sometimes you can just prop up the entire mattress with a wedge. Not a pillow that they can roll off of, but an actual wedge under the mattress that elevates the whole thing. So you can do that. You can do the reclining chair. You can get into some pretty interesting situations with sleep, particularly in adolescents and young adults. Then there's the positive pressure airway mask, CPAP. That's depicted below. It shows in blue how the current of air forces itself either through the nasopharynx, the oropharynx, and hypopharynx to keep the soft palate separated from the tongue so that the airway is open. That's probably the biggest point of obstruction. Okay, going to move along. We have about 45 minutes. Behavior concerns. So maybe 70 to 80% of kids with Down syndrome do not have a significant behavior issue. You heard this yesterday, I think, from David quite nicely. And maybe 20 to 30% do have something more significant that you could single out, put a little label on it for the purposes of calling attention to it, for the purposes of treatment services, or understanding that person a little differently than you otherwise would. That's the reason why we use these other terms and other labels. Now, even though only 20 to 30% have maybe a secondary diagnosis, there's many more children where at least the concern comes up on the part of parents or teachers. And many of the behaviors are either typical for age or stage, or they may be somewhat characteristic of kids with Down syndrome. So kids who are hypersociable, very loving, very trusting, kids who are somewhat stubborn and persistent, or have you seen that? Or kids who are somewhat repetitive and have preferred routines or the way in which they like to do things the same way. So we tolerate this, and it's kind of, once you understand it and you kind of go with that flow, it's okay, life is good, right? And you just need to tell and teach people around your child that this is who they are and how they are. And, it's one of the blessings of our kids. The behaviors that we get concerned about are those that functionally impair academics and learning, socialization, or daily function. So the ability to do for yourself, even when you have the ability to do for yourself, but the behavior is interfering. So more salient examples would be if someone's safety is involved, or if they're socially rejected by peers and excluded from activities, or excluded from a classroom placement that they would be capable of learning and doing well in, but because behavior jeopardizes, then the school may make a case for a different kind of placement. Of course, we would ask for a one-on-one aid, right? And we would ask for maybe just a higher degree of supervision. Let's do a functional behavior analysis. Let's see what's driving the behavior. So we'll talk a little bit about that. The two broadest categories of behavior that are of great concern include externalizing. So these are the kids who are like hyperactive, somewhat disruptive, and this behavior calls attention to itself immediately because it is disruptive and it can interfere with group activities. And it's potentially harmful. If you're hitting or throwing or knocking things over, that's potentially harmful to others. The internalizing behaviors are not always recognized quite as well, or if they are, they're somewhat tolerated because it doesn't typically involve jeopardizing others. But these are kids who are more withdrawn. They may engage in a high degree of repetitive behaviors or staring or a high degree of inattention. And it's difficult to engage these kids in therapies and in other activities. But there's no doubt that it interferes with their well-being. So there's a spectrum of externalizing behavior conditions. Some of them are going to be familiar to you. Attention deficit disorder. And even without the hyperactivity, you can have disorganized attention, distractibility, a kind of a low level of vigilance, and a low level of motivation. That, again, it's not in itself disruptive, but it is interfering with learning and function. And how do we separate that from a more global kind of intellectual disability or a receptive/expressive language disorder? Those are good questions, important questions, and there are implications for clinical care. You can also have hyperactive impulsive behavior, which it's amazing how many of these kids I see who have pretty good attention, really good attention. They can kind of focus in like a laser beam when they know what they want and where they want to go, and they'll climb and they'll do all kinds of things to get there. So some of their behavior is unsafe or risky. These are the kids who may dart away from you in the parking lot if you're not holding their hand, or they play that game where they run away and then they look back at you and they want you to kind of come after them. And you can ignore it to a degree, but when safety is a concern, it's hard to ignore that. So prevention and anticipation that this kind of behavior may be about to occur is your best defense against the dark arts. Hold the child's hand, use a transportation stroller, or whatever it takes to keep your child safe. That's the preeminent concern. More disruptive behaviors include when you're actually aggressing towards someone, and it may involve pinching, hitting, slapping. It may involve clearing the table. It may involve other kinds of behaviors. And a lot of this behavior is learned and reinforced over a period of time. And it may serve the purpose to either express displeasure, to seek social attention, or to escape or avoid a task demand. But once it takes on a life of its own, you've got a significant issue there. A lesser degree of behavioral resistance or behavioral resistance without the aggressive or the property destruction is more the oppositional, defiant kinds of behavior, being negative, being kind of grisly or argumentative and low frustration. And there's also a learned component to that too. Now, when you see these kinds of more significant behaviors in the setting of either hyperactivity, impulsivity, or inattention with attentional disorganization or high degree of distractibility, you can treat those components. There's a physiologic piece to that can be treated with certain types of strategies that may include meds. The other thing is you need to be able to look beyond just the surface behavior. I mean, everyone wants to comment on the behavior, where it's occurring, when, how frequently, and why. But you need to infer something about what's going on with the child internally in this marvelous brain of theirs. And you need to think about or rule out anxiety disorders, OCD, cyclic mood fluctuation, and autistic-like features and traits that can contribute to these behaviors. So behavior is a very important piece of this bigger puzzle that we're trying to figure out. Again, the problem with not understanding this fully is that life is just generally more difficult, right? Traveling, having medical and dental procedures done, just literally moving sometimes out the door into the car, transitioning between classrooms, and participation in social and community events. I mean, this is what's at stake. And so there's a lot of, I think, reason to want to solve these issues. The medical concerns that can contribute to disruptive behaviors include sleep disturbance, illness, pain, or discomfort, hyperthyroid, so if someone is really revved up, high metabolism and symptomatic with hyperthyroid. Low iron and low ferritin have been associated with inattention and, as I mentioned, the sleep problems. The kinds of pain or discomfort that are most common, GE reflux, which is not showing itself to be fully symptomatic, but is causing burning, or agita. Sinus pressure and pain, tooth pressure or tooth pain, in women, menstrual pain, constipation. All these things can contribute. But these neurophysiologic attributes that contribute, like I mentioned, anxiety and mood disorder, but also just being fatigued, being tired because you're not sleeping well at night. Or do you have these sensory aversions, right? And sensory issues. Has anybody ever seen that in their kids, right? They don't tolerate certain sounds. They don't like to be touched on the head, on the face, have their teeth brushed. So if the fire alarm goes off at school, that might create a big incident. Or if you want to go watch Big Brother play in the hockey game and you go into the arena and everybody's screaming and yelling, that may be a problem. So any kind of sound that reverberates and the child feels like they can't escape from it, that can trigger some of these behaviors. Also, just the cognitive style of the individual. If your kid is particularly inflexible or has this rigid style to how they like to do things, then anticipating change or transitioning is very important. You need to kind of go slow with that. Give them a visual, give them a photograph, a prompt that shows them doing the next thing you want them to be doing, whether that's them going up to take a bath, get ready for bed, it's time to use the toilet, it's time to go play soccer, or just whatever you're doing. A photograph is a lot more effective than you trying to bargain and negotiate with your child. And I think you probably heard that message yesterday. So I just want to reiterate that point. The treatments for disruptive behaviors, not just the safety monitoring, not just the behavior management, which you heard, not just the sensory kind of vigilance, but teach your child relaxation techniques too. A lot of kids can be taught and will engage in some self-relaxation, like folding the hands, squeezing the hands really hard, counting to 10 or maybe 1,000 to kind of keep them focused and quiet. Or do some deep massage with the child, not the surface stuff, but the deep massage that will help to relax them and calm them. So these are all practical techniques that you wanna be able to use. Okay to go to adults? Yeah? Okay, we have about 35 minutes. So here's a graph that shows increasing lifespan and estimated age of death for people with Down syndrome. And what happened in 1970 to cause this graph to go up? Really, really in an impressive way, right? Well, cardiac repair and repair of congenital heart defects and congenital GI defects no doubt contributed to that in a big way. Prior to that, the introduction of antibiotics contributed to increasing lifespan. And today, in 2010, this is data from our CDC, the mean age of death is 47, and the median age of death is 53. But we have many, many people living well into their 60s, and we expect that this kind of trend is going to continue to increase in developed parts of the world where healthcare is really delivered and it's kind of at the top of its game, so to speak. So adult health practitioners who don't necessarily train in an area called neurodevelopmental disabilities or genetics are going to experience a tsunami of people with Down syndrome coming into their clinics, including the specialty clinics. And people who live longer are going to show age-related medical conditions in a more demonstrative way. So what is the medical guidance for adults with Down syndrome? Well, guess what? There is no consensus document that's agreed upon. We know to follow up on the previous medical issues that existed in childhood, but you need to have sustained vigilance for our young adults, say between 18 and 35, for all kinds of things, such as sleep apnea, the redevelopment of sleep apnea, obesity. That monitoring should begin during childhood and is frequently showing itself around the peripubertal time, adolescence. Mood and anxiety disorders, which can start to manifest around adolescence. Hypotension, low blood pressure, bradycardia, low heart rate, which can result in lightheadedness or syncope, fainting, can be mistaken for seizures if people get dehydrated. So those are some common ones. Occasionally you'll see mitral valve or aortic valve leakage in the heart in someone who didn't even have congenital heart disease. So it's an acquired form of valvular disease. So ongoing evaluations consist of weight management, prevention of obesity, good fitness program and exercise, which is important for all of us, but it's something that you want to start early because it's hard to learn this as an adult if you've not participated as a child. And Special Olympics and other group activities are a really good outlet for those who have the interest. For others, it's going to become more of a one-on-one type thing. You may need to have a trainer or someone motivate, structure, and encourage a workout program, either with a treadmill or a bicycle, or just dancing and water aerobics. All those things are fun and good. Something to keep people active. Okay, and ongoing evaluations in adults. Not only do we continue to check thyroid, but we check vitamin D, fasting cholesterol and triglycerides, vision, hearing, dental, females with GYN care. So not every female who's menstruating, especially if they're not sexually active, does not need a manual pelvic exam. You can do a pelvic ultrasound if there's concerns about dysmenorrhea or painful menses or irregular bleeding, talk with the GYN from there. Some people are in favor of using oral contraception if cycles are irregular or particularly painful, or if the person has real difficulty managing their hygiene. So these things are all possibilities that need to be discussed with the right kind of doc. There is a consensus guideline for primary health care of adults with developmental disabilities. And I'm happy to say this appeared in Canadian Family Physician in November of 2006. So primary care physicians in Canada have some guidance. And it was based on a primary care for adults with developmental disability colloquium that took place in Toronto in 2005. And there's special mention of Down syndrome throughout the article. So it recognizes that our population has specific medical concerns. There's also an article that appeared more recently that I recommend, Managing the Care of Adults with Down Syndrome by Jensen and Bulova, appeared in the British Medical Journal just last year. And this is a very nice, concise, I don't know, is the reference given in the handout?
We'll have the article on our website.
Okay, article on the website. There you go. All right, let's talk about some specific things. Obesity. Higher prevalence of obesity, which is defined as a BMI over 30. The incidence in our adults, 40%. Other people with intellectual disability, 25, 30%. Based on the US numbers, with an estimated 300,000 or maybe 350,000 people with Down syndrome living in the US, we estimate that about 60,000 adults with Down syndrome are obese. Almost as many are overweight, and this has a major impact on health because it complicates other health conditions, as well as impacts your ability to participate, to exercise, and to get around. Individuals at high risk include females, those who have adolescent onset, those who live at home, access to food, poor control of food, and those who have few recreational or leisure activities. Hypothyroidism is often suspected, and it's the first thing people think of checking, but rarely does it explain by itself obesity. Metabolism is generally lower in people with Down syndrome, so you don't perhaps burn calories. You may tend to store calories a bit easier. Things like poor satiety or poor ability to sense that you're full, and this desire to keep eating is reported to be very common. And so it may be behavioral, it may be enabled by the availability of food, but it may also have a neuroendocrine basis in that leptin signaling. Leptin is a satiety hormone. People with some forms of obesity have what's called leptin resistance. So the leptin level gets high, trying to tell the hypothalamus, we can stop eating now, we're full. That may not be fully operational in some of our folks. Certain medications can contribute to obesity, right? Oral birth control, newer, more potent antipsychotic meds that sometimes some of our individuals are on. Certain antidepressant, anti-anxiety medicines can contribute. And then even untreated sleep apnea can contribute, because hitting those different phases of sleep during the night, there's a neuroendocrine signaling that goes on during the night. It's not just REM sleep, no REM sleep. It's things like growth hormone are secreted at night. There's a few other goodies that are secreted throughout the night that affect appetite regulation, growth and repair and restoration and healing in the body. So if you have untreated sleep apnea and really bad sleep fragmentation, there may be kind of a neuroendocrine drive to eat junk food. I know as a resident, when I was up all night taking care of the little ones, I mean, you just junk out the next day. It's sort of a craving that's there. Anyway, so chronic obesity is associated with a lot of problems, mood issues, lipid problems, but rarely hypertension or stroke. That's good. But what about musculoskeletal pain? Just complaining of pain in the hips, the back, the ankles. I don't want to walk anymore. I want to sit down, or I want to plop and drop, you know? So it contributes to all these things. So controlling access to food, having smaller first portion so that if you're going to give a second portion, it's not really a full second portion. It's a smaller amount. Use those plates with the little divided sections. Supervised exercise, and for some people, a medically supervised weight loss may be in order. There aren't many people who take that one on in our population, do they? I mean, even in the States, nobody's interested in this. Medically supervised weight loss. So what does that mean? Dietary planning and counseling, some behavioral counseling, maybe some medicines to help with appetite suppression. Certainly, if you have hyperglycemia and you're getting into a pre-diabetes, or if you have hyperlipidemia, high cholesterol, high triglyceride, those are things that you may want to treat. But there's very few programs and very few people who study this in the setting of Down syndrome, and it's a pretty important topic. Obviously, check thyroid. And if there is a compulsive component to eating, an eating disorder, not just lack of satiety, but food as compulsive behavior, then that needs to be considered both behaviorally and sometimes the SSRIs, not the ones that cause too much weight gain, but the ones that help with anxiety and OCD may be helpful. But at that point, you need to work with somebody who kind of knows what they're doing. I'm going to skip bone density, and I'm just going to give you the take-home message that bone formation is different in people with Down syndrome. So we tend to see low bone density earlier in life. And things that can contribute would be low vitamin D, low estrogen or testosterone, which may not be severe enough to cause other problems, but it may show up as low bone density over the long term. The things that are important to do are to maintain physical activity, maintain vitamin D and calcium intake, beware of medicines that cause bone demineralization. Certain anti-epileptic medicines can do that. And for those who have an abnormal DEXA scan, which we recommend by age 30, 35, which is early, right? You're going to have to talk your physician into that one. Do the dietary supplements, but also that person needs to consider whether they should be on something that improves bone mineralization, like Fosamax, Actonel, Boniva. However, it seems like those medicines don't work as well in our population. There's some suspicion that the reasons for bone demineralization are different in people with Down syndrome. So these medicines work by inhibiting the breakdown of bone so that more bone is retained. That's how they work in the typical person. In Down syndrome, though, I told you that the bone matrix that's being laid down early in life may not be as strong or as dense to begin with. So that may be more the culprit. But what accelerates the loss of that bone kind of remains to be determined. So in the final 20 minutes, we'll talk about mental health. Because I think this is something many people care about. So adolescents and adult mental health issues probably come up in 20 to 30% of the population. And I'm describing it, or I'm referring to it, as a change from previously established behavior baseline. Some behavior or mental health issues show a gradual onset or intensification of traits or pre-existing condition, like a little bit of anxiety, a little bit of sensory aversiveness that really intensified, and now the person doesn't want to leave the home. They don't want to even go socialize and do the things that they enjoyed. Or you can see a more sudden onset. Sometimes it's very inexplicable as to what causes a sudden change in someone. But I can tell you that sometimes there is an incident at work, at school, in the group home, wherever, that has the attention of caretakers, and they wonder if this is kind of a reaction. Okay, is this sort of a post-traumatic response to something that happened? It could be a physical illness. It could be any kind of an emotional stressor, or even the perception of stress, or what we would consider to be a minor stressor by most of us. You know, well, maybe not minor. You know, an aunt or uncle dies, a brother moves away, goes to college, a pet dies, something at work changed. They got a new supervisor, they changed the job duties, and we're just not comfortable anymore. So these are things that get brought up as part of the storyline, part of the narrative. But again, it's important information, but trying to understand physiologically if there's a physiologic change that's taken place is also very, very important. And I just want to tell you about one kind of a condition. I'm actually not going to talk too much about anxiety, OCD, because that's on the schedule for today. So you're going to hear a lot more about that in detail. I do want to talk about something that's referred to as major depression episode. So in the general population, we think it's more common in women. In our population of Down syndrome, it seems to be equally distributed. The risk for mood disorders increases as you go through puberty and get older. And perhaps having a history of anxiety, or even a history of other childhood condition, like even maybe ADHD, can perhaps be a risk factor for depression later on. But I want to distinguish major depression from grief reaction, bereavement when a loved one is lost, or an adjustment reaction to a new kind of difficult circumstance, maybe a divorce, loss of a relative, those kinds of things. So we expect there to be some grieving, some reaction. In the general population, they say after 6 or 8 months, it should resolve. But in our population, people may dwell and dwell and dwell and perseverate on things, and it may not resolve internally in 6 or 8 months. Then we have other people who seem unfazed by these things. They appear to not react or show emotion. And parents ask, is that normal? What do we need to do? So lots of discussion about this. But the thing about major depression is when you see it, it's no mistaking. What's interesting about it, and I'm going to describe it, there does not seem to be an increase in incidence as you get older and approach the age of dementia, which what I would just say would be, say, 40, 45, as you get into that risk period. So the peak for major depression and particularly loss of function seems to be between 15 and 25. So that's a little unusual. That's not Alzheimer's disease. That does not appear to be age-related prodrome of dementia, though we don't know for sure. And we know that this kind of depression does not appear to be progressive. And we know that a lot of these people can be helped by the right kind of treatment approach, which I'm going to tell you about. Nonetheless, the idea of, is this a precursor of some kind to dementia is still on the table for research, okay? Even though we're not calling it dementia, what's going on that puts people at risk for this? Is it this accumulation of amyloid peptide, even in the soluble form? Before you see plaques, it can disrupt nerve cell membranes, affect cell signaling, and impair neuronal communication. Is it a diminution in serotonin and other monoamines that are so important for neural communication? Is it got to do with glutamate and GABA, which controls the balance of excitatory and inhibitory signaling in the cortex and in the hippocampus? So these are all neuromechanisms that are open for discussion. Andy Warren reported 5 subjects in '89 who showed major apathy, social withdrawal, psychomotor slowing, cognitive decline, and deterioration from a previous established baseline. They were referred to him for dementia. He worked in a dementia clinic at Hopkins, but determined that these people did not have dementia. They had a severe major depression, and he reported it. And then others have gone on to report similar findings in major depression. As I mentioned, peak occurrence is like 15 to 25. But overall, there are case reports, a particularly good case report done by Prasher in 2002, who described this condition that he didn't think was even depression, certainly not dementia. He just referred to it as functional decline. And this is where you have a deterioration in adaptive and self-help skills, some mood symptoms, certainly social withdrawal, loss of speech, but not the moodiness or the irritability that you necessarily expect to see in a melancholic form of depression. And he found that this was particularly puzzling and resistant to treatment. So I was interested in this, and we have a lot of people come in for concerns about mood and anxiety. I want to tell you about a little case control study we did. So we have 2 diagnostic groups in here. In the column in the middle, we have 19 subjects with major depressive episode, 9 subjects with major depressive episode with psychotic features. Okay, a lot of disorganization and some delusions and hallucinatory-like phenomenon, not just self-talk, okay? And the average duration of symptoms, or average age at evaluation was 21. Symptom duration about a year to a year and a half. And then we had mentally healthy controls with Down syndrome. You see them at the bottom, 9 of them, fairly closely matched for age, 19.8 years. None of the individuals who were healthy controls, not only did they not have mood symptoms, they had no functional decline. These are people who are just doing well, leading happy lives. The people with the major depression, or those with depression plus psychosis, if you look over to the right, about 70% of those individuals were reported to have decline in skill. Now, it doesn't mean a complete loss of skill, which is a very dramatic and unmistakable thing, but it may refer to excessive slowing, the need for much more time, much more prompting, and much more hands-on to get people to do the things they enjoyed or were able to do before. Sometimes these folks can no longer participate in work program, school, and they need to be taken out to be given a bit of a respite while we do some medical and behavioral investigation as to what's going on. So people are quick to recognize stressors and events that may have occurred. It's much harder to find a place where you can get a good medical or psychiatric kind of evaluation. So first thing is we check thyroid in everyone, okay? So in the 28 with major depression, there was only one person who had a mild form of hypothyroidism called compensated hypothyroid. Their thyroid hormone was normal, but the system was working harder to make thyroid hormone. So that's not really hypothyroidism. And then for the controls, everybody was squeaky clean normal. So no hypothyroidism in this population with depression, okay? This is just a symptom screener that we use called the Reese scales. And in red, all the way over to the right, when you look at the statistical difference between those with depression and those who are healthy controls, we see big differences in anxiety, autism-like traits, but it's not autism, is it? Because these folks, after all, are 18 to 35. You can't just develop autism at 18, but autism traits. Depression, obviously, psychosis, withdrawal, and total score, all significantly different. But here's a cool depiction. This is what it looks like when you graph it out on one of these spider graphs, which are so much fun to make. They're so much fun to make. But this shows you the different axes, the different subscales of the Reese. And look at how much real estate is occupied under blue. That's the symptom, the total symptom burden, if you will, of people with major depressive episode. In green are our controls who are mentally well. So you can see graphically just how different these people look. When you use another scale, which looks not at psychiatric symptoms, but looks more at maladaptive behavior, such as irritability, disruptive behavior, hyperactivity, social withdrawal, repetitiveness. You also see very high levels of what's called lethargy and stereotypy, okay? So again, social withdrawal and repetitive behavior. And when you graph that out, it looks very dramatically different. So look at the amount of real estate occupied in the blue compared to the green. And that's what these folks look like when they come into clinic. It's like apples and oranges. And you hear the story of before and after. And the parents are just like, what is going on here? What is going on? So this is really, really compelling stuff when you start grappling with this. So we also decided to ask, does sleep play a role? You probably know what the answer is to this already, right? I didn't just fly here to tell you something you didn't already know. So when we did a sleep screener, and although many sleep screeners are not always that informative in people with Down syndrome, because it's based on recall, parent recall, and it may not involve close observation of the person during sleep. At least here we got a little bit of a positive signal that the parents thought their individuals were having problems with breathing, problems with sleep initiation and maintenance, and they were significantly different from the controls. So a clue was there if you knew how to ask the question. And the overall total sleep score was also elevated. This is results of sleep study. So apnea-hypopnea index was 19 compared to 4.5 in the controls. During REM sleep, where your muscle tone goes really low, apnea-hypopnea went up to 36 per hour versus 12 in the controls. Central apneas were also increased, but not significantly. And then if you look down in the lower part, oxygenation, saturation for oxygen hit a low of 83. Some kids were in the 70s and 60s. It's unbelievable. So significantly different oxygen saturations. And when you look at the severity of sleep apnea, I know this is kind of a difficult slide. So in the top row, you have major depressive episode. 54% had moderate to severe apnea. 32% had mild apnea. And only 4 individuals, 14%, had no apnea. So a whopping total of 86% of our sample had pretty significant sleep apnea. Compared to controls, only 44% had sleep apnea. So isn't that interesting? You still have sleep apnea, even in the absence of mental health symptoms. I think that's what you'd expect in a population with Down syndrome. But when they did have sleep apnea, it was mild. There was only one person in the control group that had moderate to severe. The others were mild or no apnea. And those who had previous tonsil and adenoid removal did not seem to make a difference. Or in the group, it was no different. Okay, so 43% of those with depression had already had their tonsils out. 33% of those in the control group had already had their tonsils out. Not much difference. So managing these conditions is a real problem. Not only is recognizing it and diagnosing it somewhat of a chore. What is it we're treating here? Are we treating a respiratory disturbance with hypoxemia, low oxygen? Are we treating sleep fragmentation with decreased REM sleep, decreased slow wave sleep? Are we treating a real depression, or is this somehow something that people with Down syndrome seem to develop based on perhaps frontal lobe reserve or ability to withstand chronic sleep problem as a insult or a stress to the frontal lobes? We need to figure out what the disease model is here, because it's an important one and it's potentially reversible. I'm not going to show you the data, but we do have the ability to reverse symptoms if people do well on an antidepressant medication and they're using CPAP, or they have an airway procedure to relieve the obstructive sleep apnea. Now, not everyone can tolerate those things. Not everyone gets those things, but we've seen people come back from the depths. In the outpatient setting, this is extremely difficult to organize an evaluation. You know, you're talking about trying to get like sleep medicine people, ear, nose, and throat people, psychiatry people, Down syndrome people to talk to one another, to understand something that's very nebulous. And so unless we have special programs where people understand this and know what to anticipate, and you have kind of a team of people, I don't think it's easy to make an impact on this in each and every community, whether it's the United States, Canada, or anywhere. And there's the whole issue of, can we even get a sleep study on some of these individuals who don't tolerate it? So are there alternative ways to diagnose this and get the job done in a way that's convincing enough to another physician to actually institute treatment? That's the big question. You and I can believe that sleep apnea is present and that the person has lingual tonsil. But can we convince an ear, nose, and throat doc that removing that tonsil is going to potentially make a difference for the person? And the answer is you don't know for sure that it's going to make a difference. But I think the indication to move ahead is there. So we need to develop better evidence. So again, this is the group we're trying to help. The world population statistics from World Health Organization indicate that we're going to have 2 billion more people on the planet in the next 30 to 40 years. If we use to 1 to 1,000 incidents, we can assume that we're going to have 2 million more people with Down syndrome being born. I know people are concerned about prenatal screening and what it may lead to, but most countries do not have prenatal screening, and in many countries, prenatal screening has not had a significant impact, but in other countries it clearly has, okay? So in some parts of the world, we're seeing the incidence of Down syndrome specifically drop. In other parts of the world, it appears to be unaffected. But when we go from 8 billion to 10 billion, I think we're still going to have many people with Down syndrome among us, people that we need to understand and take care of. And in other parts of the world, we need to develop at least minimal standards of care and treatment to help those individuals. And in some countries, I've had the ability to kind of meet with people, visit with people. The basic resources for healthcare don't exist for people generally the way we would want. And for people with any kind of disability, there's going to be discrimination or decreased access to care. And so the challenge of providing care is very real. And it's really families and nonprofits, non-government organizations that are stepping up, finding ways to not just increase information, but to create resources that don't otherwise exist. That's I think, a really good purpose for fundraising and for putting your energies together to create resources for families. The most common example would be developmental services, early intervention in countries where that doesn't exist. Well, so some countries have solved that one, and now we're moving on to creating better medical care and treatment. So stay up to date, spread information, create new resources. From my end, we need to create adult health care guidelines that are acceptable to the medical community. No easy job, but I want you to know that there's a lot of people now working on it in the US and internationally. So good things will happen. We need to understand end-of-life care, dementia care. We need to be ready for that. And the end game is that things will be all right in the end. And if they're not, then it's not the end. There's more to do. We learned that from Sonny Kapoor in Marigold Hotel. Great movie. If you haven't seen it, I recommend it. So thank you, Sonny. Thank you, everyone. Hope you enjoy the rest of the day.